I'd like to thank the Alcon and also the organizer and Dr. Mehta to make my job so easy. So my job is to share with you the visual performance and the real patient outcome in the clinic. I'm come from Bangkok. This is my financial disclosure. Alcon does not pay for my ticket or accommodation, okay? But they do provide nominal honorarium. We all know that 2020 is not good enough. Even you do the perfect cataracts, people come back and complain because all the unmet needs has not met. That you have heard about intermediate vision and other things. So my talk will touch on 4 areas. We'll start off with the case series outcome. So I just jump quickly to my first 30 cases of panoptics. These are all non-toric version. So this is the patient series, the first 30 cases. Lucky enough, they're all female. And female has quite an incentive to look for near when they make up and other things. So when we all start the new lens, we will worry a little bit. And at our level, sometimes patient accept no surprise. And we cannot, accommodate any surprise. And these are the age and the K reading. Let me show you the follow-up 2 days. At day 2, the spherical equivalent is not that great. But 91% is within 1 plus minus 1, which is not that great. But this is the number of cases that good for analysis. N10 for bilateral means 20 eyes. And you see that I think the side of the slide is cut off.
Can you
shrink that a little bit?
Can you reduce the magnification or something of the projection so that we can see the whole?
So we can see the...
Yeah, that's fine.
Excellent. So, I show you the uncorrected and corrected near, intermediate, and distant vision. And the outcome was not too bad if we correct that. And we know that 2 days after surgery, perhaps the refractive status is not stable yet. This is 1 month. You see a significant improve after 1 month. So every time if we see the patient too early, and if the patient complains, just ask the patient to be patient, because patient has to be patient anyway. And at 1 month, the outcome is significantly improved. And this is the post-op unit monocular and binocular outcome. And we seem to achieve quite good, even more than 1. Let me show you the defocus curve. This is the defocus curve. N9 is mean 18 eyes of the best corrected. So when you do defocus, you have to best correct first, because this take away all the biometric surprise and then make it best correct. This is the follow-up. If you look at this, as Dr. Mehta has showed the signs that if you look at 1.5, 2 diopter, and minus 2.5, they're quite good. We got more than 0.9 decibel. We calculate 2020 will be 1. So the higher the number, it is better. And this is follow-up at 3 months. At 3 months, all the patients achieve very good result, especially the binocular VA, both uncorrected and corrected distant, intermediate, and near vision. When I look at the defocus curve, and the defocus curve is quite true, reflect what the desire is. So from intermediate to near readings, minus 2.5, is quite good. And it dropped off at minus 3, because the lens was not designed to have a very near reading. It's supposed to be 40 centimeter dominant and 60 centimeter. So the range from 40 to 60 centimeter, quite sweet. So the patient has to find a sweet spot in those areas. It's more of the elongated focus from 40 centimeter to 60 centimeter. This is the binocular versus the monocular. Oh, at 1 month versus the, the binocular at 1 month versus the 3 months. What this slide tells me is that if the patient is not too happy at 1 month, just ask the patient that be patient. At 3 months, the result going to get better. I look at the contrast sensitivity, and this is the machine which tests the contrast. And like all the multifocus lens, the contrast of the multifocal lens is not as good as monofocus. So, but it's not too bad. When we look at the photopic and mesopic, it's not normal, it's near normal. This is a sample of a case, 65 years old, which I have mixed multifocus, and we see that the other lens behave differently. So it seems like the pan optics, in terms of contrast sensitivity, slightly better than the former trifocal lens. And this is not new. This has been studied that, by Ruiz and Miza, when even compared to the EDOF, is not too bad. So this new lens really perhaps employ the lost energy and put that into a better contrast, regain it into distant vision. Now, in terms of patient satisfaction, we did a survey. We want to look at the goal of happy vision. And happy vision doesn't always mean 20/20. It means that the patient can perform their activity or not. And this is the 17 questionnaires we look at. And the average of patient satisfaction is 96, which is, for us, I think we can, if we select the, appropriate patient, we can deliver such thing. When we look at the night vision, driving normally has no problem. The night driving is not too bad as well. Now let's move on to the case study. I'll show you a few cases. This is one of the very early cases that I have already implanted one trifocal in one eye. So a patient which is -5, whenever we have -2, 3, 4, 5, it's very challenging to put in multifocus because they are quite happy with their near readings because they are minus to begin with. And the left eye was like that, -2.25. So this is quite a challenge case. I did the first eye in 2017. We put in the one of the trifocal lenses, which is the five vision visual. And this is the outcome of the right eye, which is able to get -5 to a low minus on auto-refraction on the right eye. The left eye has not done. So back to this. I did the left eye in last year, 2019, and put in the panned optics, 19.5. This is the outcome. So when we look at 40 centimeter and 60 centimeters, it seems like it's more favorable result on the left eye, which is the pan optic, versus the other eye. But let me remind you that the test was done as 40 centimeter and 60 centimeter. When you compare not apple to apple, then maybe, but if you look at 40 centimeter, this lens is designed for, it outperforms the earlier five vision trifocal. And this is the defocus curve. The right eye is the former trifocus, the first eye, and the left eye, the second curve is the pan optics. So it seems like the pan optic, the left eye, outperformed the right eye quite a bit in this case. when we do binocular, the patients see quite okay. There are comparison study, which I'm not go to detail. You can read all this, by Candice and compare the fine vision to PanOptix. Just go ahead, read that. But what they say here is that at certain focal point, one lens can be better than the other lens. I think for us as a surgeon, we have to understand our patient needs. Whether it's short arm, long arm, whether what type of work, is that a PC user or, people are different. And then the good thing is that we can tailor-made and try to meet that visual requirement of the patient. I just go to my last part. Oh, this is the second case, the panoptic bilateral. A lady, 68 years old, and then come for use hyperopic contact lens more than 20 years, use iPad for 5 to 6 hours a day, and watch movie, but not driving. So we discussed about the options, and then I did implant the, this is pre-op biometry, and this is the outcome. So the uncorrect distant vision, intermediate vision, and the near vision is not bad at all. But when we come to very near focus, it's 20/40. And sometimes if we have the patient who on contact lens, we have to make sure that the patient have been off contact lens for enough time. I think we can entertain the panel on what is your cutoff, 1 week, 2 weeks, or 3 weeks. And this is post-op 3 weeks, the vision become better. Again, the lesson learned is that if the patient is not too happy with the very early post-op, just ask the patient to be patient. The vision going to be better, reassure them that it's going to get better at 3 to 4 weeks. And if they are not too happy with at 1 month, at 3 months, there will be more improvement. So if that patient is on contact lens, we have to make sure that the patient is off contact lens long enough, otherwise there might be a slightly hyperopic chip. And this is her defocus curve. When we do binoculars, it's quite good. And this is compare, again, day 2 and 1 month. At day 2, maybe the patient was not to have the wow effect, but at 1 month, after they adapt to the new optics, I think the outcome is quite okay, and we can reassure them for that. I'm going to move to the last part, which is I have luxuries of using the Aura system. Many of you understand Aura is the intraoperative barometers. So I have 2 Aura systems, one in each different hospital, one in private, one in my university. Sometimes we employ LenSx as well, the femtosecond cataract. And this is just to show you the last part of the talk on the video. This is the patient coming in, and then we use the Varian to first look at the eye and then just send the data to LenSx. I just skip to the part that we use Aura. So this is after phacoemulsification. And then, before we implant the lens, this patient, we have pre-select 19.5, and then we just draw in the barometer, ask the patient to look at the light, and then once you train, it's a quick procedure. It doesn't take that much time. This is real time, normal speed, and then it's give me that this patient perhaps should have 20 diopter, not 19.5. So we do that few times, 3 times sometime, and then this is putting in the lens. I can share the when we compare the outcome of using aura or not using aura. But you don't need this for PanOptics, because I think when we look at the A constant that the company provide and do our outcome with or without aura is quite reliable with that A constant. And this is the aura V-link, which is the last part. The V-link has more control on the surgeon, so you can see all these numbers coming up in the eyepiece, in the objective lens. So in summary, I think PanOptic performance is providing satisfactory performance, and that may be perhaps from the light utilization that you heard from Dr. Mehta on the optic design. The visual outcome usually more favorable at 1 month, not the first week of surgery or few days after surgery. They're more accommodative for near and to intermediate range. So it's kind of from 40 to 60 centimeters, the patient able to see, to perform that task quite well. And could outperform some of the trifocal, IOL, or even EDOF if you compared various studies. But it's subject to patient profile, what the patient needs, what are their sweet spot, what they want in their daily life, and could achieve a more happy patient. I thank for your attention.
Thank you. I think from both these presentations, few things did come